So a very good morning to everyone, and especially all the senior professors who are here much before time the residents are. So anyway, so I was going to request the residents to please join us on this side so that I can be interactive with them, but as soon as they flow in. So the key points is, this is a talk on the radiological update of assessment of fibrosis. A lot has been said in the previous lecture about what is fibrosis and the histopathological staging, etc. So I'm not going to go into details of all that, and I'm just going to go into the fact that why are we looking at fibrosis in such a, in a very focused manner, and why are we focusing so much on fibrosis? It's the need of the hour today. And we know that the degree of liver fibrosis with CLD in a patient with CLD will predict the likelihood of developing further liver-related morbidities and death and many other prognosticating things. So it's very important to prognosticate these patients, and fibrosis is one of a very important marker for that. We also need to stratify our therapeutic and surveillance strategies, and for that again we need to know how much fibrosis a patient is developing or has it or not. We need to evaluate the response to treatment over time, and then of course fibrosis is the key surrogate and the endpoint for clinical trials following allowing expedited approval of drug treatments for such patients. So we know that fibrosis mapping is important for surveillance, for screening, for diagnosis, for prognostication, and for therapy. So when we need this marker for so many things, we need to understand how to go about quantifying fibrosis. We need important methods for that. We've seen that biopsy is one of the so-called gold standards today, and I will come to that at the end of this this lecture, is telling you that biopsy is no longer going to be the reference standard or the gold standard for evaluation of fibrosis. So we're all looking for desired methods. What is the important criteria for these desired methods? They have to be accurate, they should be precise, they cannot be qualitative, they cannot be subjective to a reader. They have to be quantitative, they should be measured, and that's where imaging and radiology and other biomarkers are coming in. They have to be reproducible. It should be reproducible over centers, over states, over countries, and they have to provide the same results for varied populations on repeated measurements. Why? Because we need to evaluate these patients over and over a period of time, and so they have to be reproducible as well as repeatable and have the least error possible. They have to be dynamic. So our measurements have to be dynamic. Why? Because we need to have a response to fibrosis levels over time. And how do we measure that? Does it have to be the same modality? Does it have to be two different readers? What is better for us? And we will see how we go over the slides, how it should be. It should be, of course, acceptable to the patient and the physician. And biopsy, we know, is not a very, very acceptable method, and I'll show you how. The accessibility and cost effectiveness, of course, are important if we are to take this to a surveillance or to a screening program level. So what is the current paradigm? Like I said, ultrasound guided liver biopsy has been called the best gold standard which is available today. Just having a look at this needle here would tell you how much would a patient be willing to get a liver biopsy done. If we need to get it done, we would be very, very apprehensive about it, and all of us would want to go in for a non-invasive marker for that. The sampling bias also, of course, limits the applicability of the method, and it is even then, it is a semi-quantitative measure of fibrosis, which is what Dr. Archana had talked about last time. It may not be sensitive to subtle changes in fibrosis over time. And of course, we have the grading on fibrosis on biopsy also from 0 to 4, or let's say 5. So there are only about 5 levels of measures of fibrosis even on a biopsy. You may not have a sufficient length of biopsy scoring system. You need an experienced pathologist. You need an ultrasound guided measure. So you do need all these variables there also. In a tertiary center like ours, maybe an experienced pathologist or to get a sufficient length or to have these modalities is not a challenge. But if we look at other places, other centers, if we want to make this into a screening or a surveillance program, we need to have measures which overcome the shortcomings of a biopsy, which is why we will be following a reference standard over the years, which will be different from histopathology. I know that contraindications to a liver biopsy are relative now, which is why I've called it relative. And we know that coagulation disorders, lesions, amyloidosis, or other diffuse infiltrative diseases, ascites, and congestive liver diseases are confounding factors to biopsies. So if I'm seeing some students there, please feel free to come to the front. So because of all these, we move on to imaging biomarkers. And like I said, there are many biomarkers. We have indirect and direct biomarkers and combinational panels, proteomic profiles. All these are now coming together to give us a staging of fibrosis. Liver biopsy is just one of them. And of course, liver imaging is a very important part of these imaging biomarkers. Now, if we have to divide these biomarkers into two main categories, I would say that either they are morphological or they are quantitative methods. When I say morphological, we mean that when we look at an image, that's a morphology, or that's a subjective analysis of the anatomy of the liver, and that is a morphological parameter. There are many studies today which, if you look through PubMed, many studies today which talk about the morphology, and I will show you some finer aspects of that as well. But these, as we know, are very, very subjective, and so they cannot be used as a standard reference guideline for imaging as a biomarker. There are various quantitative imaging methods, and that is what we are going to focus on in the rest of my slides, so that you know what are the available quantitative methods and which are the ones which can be of application or use to us, or in the coming years would be coming up as modalities. In the past recent years, parenchymal stiffness, restricted diffusion on MR, T1 relaxation maps on MR, liver surface nodularity can be seen both on CT and MR. Extracellular space contrast accumulation and elastography have been the mainstay of imaging biomarkers using quantitative imaging approach. Like I said, the above four are pretty much to do with MR and other modalities. Liver surface nodularity works on both CT and MR. Extracellular space contrast accumulation is a post-contrast study which we do on MR. And most of these are using MR because of the non-radiation capability, as well as a few other factors. Now, the key points even with these modalities remains whether mapping is going to be a screening versus a diagnostic tool, whether it's going to be using a single modality or multiple modalities, or we should go in for a combination of tests. Should we have an imaging panel of serum or indirect direct biomarkers along with imaging? Is that better? Or we do them as a sequence? So we have to look at how we go about mapping also. Like I said, imaging methods, they're not sensitive signs for detection of early fibrosis stages, particularly NAFLD. So it is across the board, I would say, any modality that I'm going to be discussing today, imaging methods are not sensitive for early fibrosis, especially in NAFLD. Diffusion-weighted imaging and intravoxel incoherent imaging. This is just a refined form of diffusion-weighted imaging where we look at molecular movement in a cell during an MR scan, and they're very attractive non-invasive options, but they have not been standardized over all these other different scanners and countries, so they are not being used very often. The repeatability across scanners is poor to moderate, but having said that, I would say that MR is still the best modality to work on a moderate basis of inter-companies or inter-vendor strengths. And they haven't found wide clinical application in the evaluation of fibrosis because of these methods that I've mentioned here. Now, why dynamic elastography? Elastography happens to give us a continuous vibration method where we can assess the liver over a period of time and measure a larger volume. So stationary waves are produced, they're induced into the body, and they analyze the tissue elasticity. I will show you more of that. These technologies are better suited for MR as vibration time is not dependent but assessed in a volume, like I said. So coming back to morphological changes, which are the changes that we know? We know that irregularity or hypertrophy of the left lobe. We know that there is nodularity of the liver surface, increase in space of the gallbladder fossa, increase in periportal space, increase in the volume of caudate lobe, and a posterior hepatic notch sign which talks about the right hepatic lobe hypertrophy versus posterior segments versus anterior segments. So all these signs, we know, we see them on imaging every day, and they have been used to calculate the volumes or ratios in various studies, and many centers continue to do that as markers. So these are markers too. I'm not saying that they're good or bad, but in comparison to quantitative methods, they haven't stood their ground over a period of time. Coming back to elastography, it's a conundrum. We have ultrasound elastography, we have MR elastography, and there is a difference in staging in many, many stages. What are the main issues with elastography? It talks about the difference in burden between adjacent fibrosis stages in the CLD continuum and has an impact on its performance. When I say that, when we keep liver biopsy as a reference standard and then we compare elastography with a biopsy, it's really not a true reference standard. Why? Because a biopsy talks about the fibrosis at a particular sample of liver volume that you have taken, and it talks about a particular period of time. So that moment, at that portion of the liver, the biopsy gives you a standard. That cannot be the reference standard because it's not talking about fibrosis as you move over time. So biopsies, the fibrosis in January versus the increase in fibrosis up to February or March is not something that we could sample on a biopsy on a regular basis. So a difference between a sudden progression or an early progression of disease cannot be staged using a histopathology method, and that is why elastography as a reference standard with biopsy has not worked out well. So what I'm trying to say is that studies which have mapped these two as a reference standard may not be giving us the right or the exact results. We know that across the board, performance for all imaging has better accuracy for stages of 3 and 4 fibrosis versus stages 1 and 2. But it is also a known fact that histopathology gives us intermediate stage fibrosis. It is also not a very, very accurate method. It is, having said that, elastography methods are better to distinguish advanced versus early fibrosis, and that is what we really need to figure out for these patients. They're less accurate in adjacent stages, which means I'm not able to tell you whether the patient has a stage 1 or a stage 2 fibrosis. I cannot tell you whether this is 2 or 3. So if the patient is somewhere between 2 and 3 or is mildly ahead of stage 2, it's very difficult for any imaging modality to tell you where at this point of time this patient is. But said that, elastography provides a continuous quantitative number compared to the semi-quantitative staging, like I said, which is a maximum of 5 stages. Biopsy takes location of fibrosis in consideration, whereas elastography is regardless. So having said these things, elastography is coming out as one of the most important biomarker for imaging of these patients today. Now we will come to what is the principle, a little bit of physics of what is the principle of elastography. Tissue stiffness is just a surrogate marker for fibrosis deposition, and that is what we are trying to mark. So we are not looking at the fibrosis, we are looking at the stiffness of the tissue, and we are, because it's directly proportional to the fibrosis, that is how we are mapping stiffness with fibrosis through elastography. So a shear or a shear wave of examined tissue is produced, and like we studied in our school physics, there is a smaller strain in hard tissues, which means sound or any wave propagates faster in solids versus softer organs, water and air. So we studied that solids propagate sound faster, which is what we look at in elastography. We send in a wave and we map the time or the time to echo back of those waves. Faster the propagation, the more stiff the liver, the higher the fibrosis in that liver, which is what we are mapping. What are the commercially available techniques? Commercially available techniques is real-time or strain tissue elastography, which used to be a method of the past now. Transient elastography is what we are using here in ILBS for many, many years. And RF, which is a caustic radiation force, that is just a different way of sending in waves, and so is shear wave. So RF and shear wave are just two different methods of producing waves. They all produce waves. So does a Fibroscan, so does a strain tissue elastography. So do I have some residents here now in the house? Are there some residents? Okay, so we'll come to them. So the EFSUMB, which is the European Federation, has mapped these into two main methods, the strain elastography or shear wave elastography. Strain elastography is a quasi-static. That means the waves produced are not produced over a period of time. They're produced, then they stop, then again we send a burst in, and then they stop. So they're quasi-static. They're qualitative because what they do is when you press a structure, like those balls that you have, those rubber balls which you ask the patient to, to press, you press the ball, the shape changes, and then when you remove the pressure, the shape comes back to the original structure. So what strain elastography does is it produces a strain, it sees the impact of the shape of the structure, and it decides whether this structure is, how hard it is, how much is the shape changing. That is a quasi-static method. A different type of strain elastography is real-time, which is a semi-quantitative. They both are not completely quantitative methods, and that is why I have now not found too much favor with the quantitative mapping. They're external forces, so it's very difficult to quantify. It's difficult to quantify how much force I put on a ball versus how much you do. So it does not provide absolute measurements, which is why it has not taken favor. It's not been used for liver fibrosis staging at all, whereas many vendors say they claim that they do, but it cannot be used. It's usually used for superficial structures like the thyroid or, let's say, breast lumps. Now, what does shear wave elastography do? It's a quantitative method. Like I said, we have three main: transient elastography, which we're using, a point shear wave acoustic method. It's again an RF produced method. I'll show you the images and show you what a point wave looks like, and a real-time shear wave elastography. Now this real time is different from the other strain real time elastography. This is a shear wave and that is a strain wave. So both are very, very different. In a shear wave, what happens is we give an external or an acoustic push, and when we measure the Young's modulus. So I'm not going to bore you with the physics, but the Young's modulus is, you can go back to your physics and read. This is what the three modalities look like. Tissue deformation, like I said, this is a little tissue lump and then it changes its shape, and that's what we are trying to measure in a strain elastography. This is a shear wave method that has found favor now. There is a shear wave elastography now available in vascular lab, and which is what we did our study on. And now we have in our department another machine of RF, which we have just recently acquired, and we're going to be doing much more elastography with that. So this is the principle of RF or shear wave, where you put in the wave. It's a dynamic method. There is a continuous push, and then you look at the quantitative measure of how much stress it has created in that and how much is the time taken for the wave to come back. So you put it in a perpendicular fashion, but the waves are spread they spread transversely, and that's what we measure. What do we do in a transient elastography or a Fibroscan? We push in the waves with the mechanical transducer. There is a vibrating force. All those who have had Fibroscans in their checkups, you must have felt a little push that comes to you when the probe is put onto your intercostal space. You can feel the vibrator moving. So that's nothing but the pressure being applied, the wave being applied by a mechanical vibrator, which sends vibrations in and then maps the acoustic waves which are coming back. Like I said, strain elastography usually used for breast lumps. This is the elastogram that we get. So you perform at least twice. You put in two pressures, easy to apply. And then we look at the stress distribution and we try to quantify that. And the experience of investigator is very important in strain elastography. You have to choose the right angle. The stress has to be directly applied by the operator. You haven't seen much of it. We haven't seen much of it because it didn't really take up. There are still many centers which use strain elastography for breast lumps or for thyroid and other superficial, like even lymph nodes, you can use it. So like I said, it's not useful for abdomen or liver and pancreas. Coming to real-time ultrasound elastography, like I said, this is a semi-quantitative method. The software will measure the ratio between the lesion and the normal parenchyma. So there is a lesion here. What the software will do is, it will send in waves. You see the map here, and then you see the ratio. So you look at the wave here, you look at the wave here, and then you decide, you take a ratio. So it's quantifying hard versus soft. So in the same parenchyma, we are taking a ratio of a normal versus abnormal tissue, which is a suspected tissue. And then we see whether this is a abnormal tissue and to what extent is the hardness of that particular tissue, which is why I said it's semi-quantitative, because it compares it with the supposedly normal tissue in the background. This again is not workable for the liver, because we know that when we are looking at the liver, we want to see, we don't know which are the normal portions versus abnormal portions, but it can be used for focal lesions. I'm not going to be covering focal lesions in this talk. So coming to Fibroscan, which we are so used to every day, like I said, there's a mechanical vibrator. It creates displacements. There is no image formed, which is why it is called a 1D technique. It's not a 2D, it's a 1D, because the waves go and the waves come back. It has been the most studied and validated technique, probably because of the outpatient facility that it is available in many, many centers. It is patented by EcoSense. Like I said, the transducer probe is along with the axis of the vibrator. So there is a vibrator behind and the probe is mounted on top of the vibrator. So there it's a one appliance, it's a one structure. This is the one. So the vibrator is here and that's the probe. And then we calculate the velocity and amplitude of the shear wave, which is measured back from that segment which we are examining. And it calculates even the wave attenuation. Now I have a few questions for the residents. There is no grading, so please feel free to shout out, which is why I wanted you in the front. So tell me, for pre-Fibroscan, how many hours do we ask the patient to fast? Anyone? You have to say any random number. This is not a test. Anybody can say anything. This is the most routine examination that you all write in the OPD, that we all get done. Our relatives come. We must know these things. So anybody, please shout out. How many hours of fasting do you know you want for a Fibroscan?
Residents may come in the front.
Okay, I'll give you MCQs. 1, 2, 3, and 4. How many hours of fasting do you ask for? Very good. Why? Why do we need a patient to be fasting? And in continuity with that, I'm asking you the second question. Supposing a patient has had his breakfast or food and you carry out a Fibroscan in a postprandial time and the scan is normal. Let's say the elastography is normal. Would you want to repeat this scan or no? No. Very good. Why not? Very good. The answer is no. You don't want to repeat the scan because the patient is its scan is normal. Patient was not fasting. The scan is normal. Why don't you want to repeat it? And when do you want to repeat it? Shiva, you can't be answering. Any resident? Come on. Okay, so obviously hepatology residents not here or what? Okay, only faculty is here. All right. So postprandial, we don't repeat it because we know that there is an increase in stiffness of the liver after meals. And we know that the liver is going to be more, it's more congested. So it's going to be harder, more stiffer. If in a postprandial scan, the scan is normal, there is no need to repeat a Fibroscan and ask for it again because you know that it's normal. If after a stress, it's like a stress test for the liver. It's like a stress echo. If you have a stress and the liver is still normal, there is no need to repeat it. And we need 4 hours of fasting because we need to make sure that there is no increased blood flow and there is no increased stiffness in the liver. These are some things that you have to know, that there is no way we cannot know in an institute which carries out Fibroscan thousands every day. So what is the position for carrying out a Fibroscan or any other elastography method on ultrasound, and why do we use that? What position does the patient lie down in? Right side up, left side up, supine? How would you want to do it? Right side up? Supine? Yes. So I hear a few residents say right side up and supine, but they're all radiology residents. Okay, so why? Why should it be like that? Would you ask the patient to do something else when you're trying to take a Fibroscan? You ask the patient to move his hand up his head. So the patient has to have an elevated right upper limb above his head. Why? Why do we need that? That's a very important thing. Why? You need to expand the intercostal distance. So the intercostal space needs to be expanded so that you can put a transducer in and get the best window for putting in your waves into the liver, which is why you must have that. There is a sweet spot for Fibroscan, or there is a sweet spot for ultrasound elastography. What is that? Does anybody know what is a sweet spot? Okay, we'll talk about that later. What is the angle of transducer to the liver? It's very easy. Very good. Again, radiology residents. I don't see anybody else answering. How many measures do you take when you take a Fibroscan measurement? We've all had it for executive health checkups or otherwise. How many measures do you need? Very good. Anybody else will answer from that side? Okay. What is that? How is the total value calculated? How do you calculate it? What is the statistical measure that you take? It's not the mean. It's the median. Yes, it always has to be the median. Whether you take ultrasound elastography or you take Fibroscan, it's always the median value with the standard deviation. And what is CAP? Come on, all your studies are based on CAP. What is CAP? Sir, you can't answer. What is CAP? Okay, so sir has already answered. It's controlled attenuation parameter. Which probe is it available on? When we go for Fibroscan, which probe does CAP have? We have to use a particular probe for CAP. And what is the recommended probe for CAP? How many probes are there in Fibroscan? Sorry? How many probes are there in Fibroscan? This is basic. All of you need to visit your Fibroscan room today. When you're listening to a lecture on Fibroscan and elastography, you have to know the basic stuff, what's going on in Fibroscan room. Please go. There are 3 probes in a Fibroscan machine, which is a small, medium, and an extra large. And most of the times we're using a medium probe for adults. Small probe is usually for children. It's used for pediatric age group. And an XL probe is the one which is recommended to find out the CAP measurements. Medium can also be used, but XL is the probe which is to be used if you really want to find out the fat estimation in the liver. How to choose, which I've just told you. Avoid which 3 structures? Which are the 3 structures we avoid when we're looking at somebody's liver? 1, vessel. 2, bile duct. And 3, any mass. So liver must not have these 3 areas mapped. Okay, so these were basic questions for the residents. Okay, so now the new machine that we have is a new Fibroscan 502 touch system. I will not go into details. I've already told you a lot of this. So XL probe is the one which we use for little obese patients or for thick skinned or thick walled patients. It is the most important probe to be used, and many studies are coming up with how XL probe is going to be the probe of importance for studies and for measures. The automatic calculation is by the machine software. It uses 10 median values, and the cap is also computed from the same probe or from the same measurements which we acquire the liver stiffness from. So it's valid only if the value for the stiffness is correct. So if you're calculating the stiffness correctly, only then the cap is the correct measurement. Otherwise, cap cannot be defined as a right measurement which has been taken. This is what the Fibroscan rays go inside. This is a 1 centimeter diameter, 4 centimeter long probe which has a vibrator and the transducer on top. I've already mentioned many of these things in my questions before that, but most importantly, the depth of the measurement has to be 2 centimeter below the liver capsule and at least 6.5 centimeter from the skin surface, and that is the sweet spot of getting a Fibroscan or an elastography measurement. I've shown you all these. Okay, so now this is what the Fibroscan used to look like earlier, or in the new machine it's a little different. So this is a normal study. It's a 1D technique. We take 10 values. Everything is given on the report here, so we must know how to interpret this. Many normal stiffness measurements are given. CAP, they say, has been outperformed by the MRI PDFF sequence. It is a point of care technique. Some words about CAP, very important. It's only validated using XL probes, especially for NAFLD. It's a good modality. No defined cutoffs have been given for CAP. So whatever we are using is a vendor prescribed cutoff. It is not a standardized cutoff. There is an influence of the BMI, and diabetic patients have different CAP values. They cannot be merged or combined with the other population. This needs comparison with ultrasound grades. There is an overlap in grades. We have seen that CAP overestimates the fat estimation when you compare it with ultrasound, because there we can actually see the amount of fat in the liver. The quality criteria has not been defined. It does give good performance in advanced fibrosis with fatty liver together as conjunction. It is definitely a better modality for children, and a CAP of 249 rules in liver steatosis. This is one of the good studies of CAP, that more than 250 will rule in steatosis for any patient. So I'm going to skip these in the interest of time. What are the confounding factors for Fibroscan? So a patient with fatty liver, that itself is a confounding factor for getting the right values for stiffness. Patient with inflammation, biliary obstruction, venous congestion, any other infiltrative disorder, postprandial state, and excess alcohol. So patient coming with an alcoholic binge, if you send him for a Fibroscan, you're not going to get the correct value. So all these things need to be kept in mind when you're asking for a TE scan. Having said that, what are the advantages? It's comparable to that of serum markers. So if you don't want to even get serum markers for a patient, just go ahead and do a Fibroscan. It's very fast, very easily reproducible. It's validated in all CLD types. Many studies have been done. It is definitely helpful in predicting outcomes, and it differentiates between advanced and early fibrosis, which is what we need to know at the point of care when the patient walks into your clinic. Use along with serum markers increases your accuracy, so you can avoid liver biopsy in chronic hepatitis patients. It is the best for significant fibrosis markers only. It's an excellent tool for early detection of cirrhosis, and it has prognostic value for fibrosis progression as well as regression post-therapy. We must use it before, during, and after. It should use the same scanner and the same operator preferably, and that holds true for all modalities, and it will help in predicting outcomes. Like I said, many limitations. Its operator experience is the most important. It's a blinded technique. You don't know where the probe is being put in. It's difficult in increased visceral fat. So if a patient has a thick abdominal wall, is obese, has ascites, there has been some breakthrough with the XL probe, and they are coming up with advanced technologies with that. It's an unreliable measurement, even having taken all these in consideration, almost 20% of patients. And of course, the exam takes 10 minutes and 10 measurements and all of that. And you need to recalibrate the spring which pushes in the pressure every 6 months. So if that has not been recalibrated, it may be not giving you the correct values. Like I said, RFE is just a technique of shear wave, and I'm going to rush through these slides now. So higher the speed, higher the fibrosis. You also need 10 measurements for point shear wave and 2D shear wave. So shear wave is of two types. There is a point method, which is what I'm going to move to that. So this is what a point shear wave looks like. This is what we have in our department currently. It's also one of the best techniques. So both 2D shear wave and point shear wave are similar techniques. They have been validated in various studies, and they are supplied by different vendors. For example, point shear wave comes with Siemens, Siemens, with GE, with Philips, and the 2D shear wave comes with Atlas or with this Toshiba and other vendors. So there are different vendors which provide different techniques. Shear wave is good. It's a good elastography technique. It gives good to excellent agreement across ultrasound systems. It measures the elastography in meters per second, which is the velocity of the sound which is coming back. No map has been generated, only values are given, and you find the median of the values and you get a map. Of course, accuracy decreases in all obese patients, and which is why now the AI methods are bringing in tools where the machine helps you find a setting or a place in the liver which gives you the best measurements. In 2D shear wave, which is what we have on the first floor, ROI size can be changed. So you get an elastography map, you put in the map, and then the operator decides where to put in the ROI, and then you get measurements from this ROI. Again, you have to take multiple values. It's a real-time imaging. You can get the map and see the color coding, and then decide where is the uniform coding, and you can put in the ROI there. It gives a higher spatial resolution. This is measured in kilopascals, and there are many normal values which have been defined, but having said that, I would like to say that all of these values are vendor specific. So each machine gives a different set of values, and you have to go as per the vendor. This is not being standardized by institutes but by vendors, and we have to follow what the vendor gives us. Of course, doing this technique, we need to know that the measurement in right lobe is more important than the left lobe. Why? Because the heart puts a pressure on that. Because of the poor response in the last question break, I think I'm not going to get a very good response this time also. Does anybody know what CACLD stands for? Hepatology. Anyone? What does STARD stand for? What is liver STARD? What is the rule of 5, rule of 4? What is QIBA? Anybody knows? Okay, I'll cover them in my slides next. So what are the limitations of ultrasound elastography? We saw it's very good. It's a very good modality. It's again operator dependent. There are artifacts from the liver capsule, from the thigh body wall thickness. All these parameters will lead to limitations of elastography. QIBA was an alliance which was formed by Quantitative Imaging Biomarkers. All these different studies and vendors, so all of these countries came together to form an alliance where they could quantify and standardize these methods. They have defined imaging protocols, how a study should be done and how to standardize and get image acquisition. You can go through these papers. Like I said, the sweet spot is 2 centimeter deep to the capsule of the liver and at least 6.5 centimeters from the skin surface. So that is the ideal method from how to get it. New tools have come in and increased acoustic penetration. That means they're now coming out with techniques and to map obese patients. This is the WFUMB, which is the World Federation of Ultrasound, which has come out with their guidelines. The rule of 5 is nothing but measures of 5, 10, 15, and 20. This is how you will map, and this is how you will actually divide your patients into groups. The rule of 4 has come out through Society of Radiologists for Ultrasound, which says 5, 9, 13, and so on. So 5 to 9, 9 to 13, more than 13. This is just grades of fibrosis, and it gives you a prediction of advanced chronic liver disease, and C stands for compensated advanced chronic liver disease, and this is what they are looking for, which patients are compensated, which patients are going to be falling apart and they are going to go in. So I am falling short on time, but I've already mentioned all of these. This is what a liver surface nodularity will look like. So these are all techniques which are coming in with newer advances. We look at the surface nodularity of the liver and we try to see and we try to grade that. That is done by a software. We can do a T1 mapping of the liver. Again, you will try to take a map on the non-contrast study on MR, use a software and get liver values for that, and then look at patients with and without fat or with and without fibrosis. MR elastography, we've talked about it. This is the Elastogram Map, and this is what the anatomical map looks like. Again, we get values in kilopascal. A word about textural analysis and artificial intelligence. Textural analysis image would look like this. So all these images are coming out with softwares where you can map the surface of the liver and see how hard or how soft it looks, and then you can quantify these values on different patients. Artificial intelligence, the role would be to incorporate this artificial intelligence method for acquiring images with which you can take out and see the best portions of the liver to define. So many papers have taken this. So the take-home points, there are many, and you can share this with me, but most of them I've covered. This is assessment of response to treatment is important. Post-treatment improvement, remodeling will take years in a liver to happen, which is why we should not just look at the morphology. We have to look at the values. The patient may be treated, but the fibrosis values may be still high or they may be low. We have to treat according to the values and not how the liver looks like. Right, so this was a paper we had from our center and we can share that with you. So the only take-home protocol that I would like to give you is the IEL-based protocol which we could follow is this rule of 5, 10, 15 and 20. Patient less than 5 kilopascal, you can call him normal. 5 to 10, you have to start looking for, you have to start looking for an advance in fibrosis. More than 10, you have to rule out compensated advanced chronic liver disease. More than 15, you can rule in that the patient has compensated advanced chronic liver disease, and more than 20 you have to look out for varicose bleeds or any other such factors which will lead to a decompensated patient. So new reference standard is going to be in the offing of quantifying for fibrosis burden that will correlate with the outcomes and the ability to predict complications rather than the amount of fibrosis and quantifying it in a patient. That's it. Thank you.